Hi, and welcome to Here for Health, the podcast that is your information source for healthcare in almost every aspect of the word. Today, we're very, very fortunate to have with us the CEO and president of GD. I'll have her tell you so that I don't mispronounce it. Her name is Dr. Stacey Goldstein-Dwyer. We'd like to introduce Stacey. May I call you Stacey? You prefer Dr. Stacey? What would you like?
Stacey's fine.
Okay, Stacey. Stacey has a breadth of experience in the mental health field, and we've been chattering on here about what the issues are, because we really want to focus on anxiety and depression today, but whatever else she wants to bring up. And you had some very interesting comments on autism and on neuropsychiatric. Could you tell us about your perspective on that?
Sure. Well, Dr. Lewis, thank you for inviting me today to be here.
Yes.
Did you want me to talk about the autism piece, or
whatever you want to talk about? But I just whatever you think our audience would like to know about.
Sure. I think the most important thing to think about, at least from a mental health perspective, and our two major populations that need assistance, is those who have autism and or ADHD. We are seeing more and more individuals come in, older individuals who have been unidentified when they were younger. There's more knowledge out there now. There's more assistance. They're seeing it in their own children. And so now they're seeking help as well. And they're looking to get an assessment to determine if they are indeed autistic, or on the spectrum, the autism spectrum. And then kids as well. And we're seeing more and more. I don't know about other areas, but I can tell you we're seeing more here in New Mexico that have that need. And we've just opened up a location in New Hampshire, and that has also been an identified need. And there's not as many evaluators anymore to be able to evaluate for those services. In addition, there's not a lot of therapists who specifically are trained in working with neurodivergent individuals or those who are on the autism spectrum. The other problem we're seeing is individuals coming in for ADHD testing, or they come in for other testing, say autism or neurocognitive disorder, or looking for psychological evaluation for anxiety or depression. And we're seeing this ADHD diagnosis come up more and more and more. And what we're seeing it, as I call it, or I label it, it's not a industry term, is a therapeutic or psychiatric diagnosis of ADHD. It's where someone opens up the mental health manual, or Bible you might say, right? That tells you what your criteria is for you to meet that diagnosis. The problem is there's a lot of overshadowing symptoms, symptoms that are that present the same for, say, someone who has autism and ADHD. What I'm talking about there is someone who has a hard time with what's called executive functioning and cognitive functioning. Executive functioning are those higher level tasks, problem solving, multitasking, following multi-step directions,
like most of us do every
speed.
day.
Right.
Yeah.
And if you have ADHD, you're going to have problems in those areas, right? But and you're going to hit yes for all that criteria. But think about all the other diagnoses that could also present the same.
Of course.
Depression, anxiety, autism, neurocognitive disorder, traumatic brain injury, PTSD, right?
Which is a lot of diagnoses under just a small subset
Absolutely.
of symptoms.
So without executive testing, without testing that specifically focuses in on ADHD or areas of executive dysfunctioning and cognitive dysfunctioning, you would imagine or would expect for someone with ADHD, you may on that testing find out, well, in these areas they're actually doing fine. But because of this, they struggle in these areas. Because of this, they struggle in these areas. So it's really about parsing apart that information, and then after getting that evaluation, knowing where to go with your treatment. If you are being treated for ADHD and you have autism, but you don't have ADHD, guess what? Your autism symptoms are going to increase.
Wow.
They're not going to get better with
They get
ADHD
worse.
medications. They typically get worse.
So you would think that if someone was, as you say, misdiagnosed and taking medications for it, they may very well feel that this is of no value to them whatsoever and abandon mental health therapy
Altogether.
completely, because it's a hard enough thing to even start that.
Yep, and get
'Cause
very,
they're-
very frustrated.
Yeah.
And then we have a lot of people who come in for ADHD evaluation, strongly believe they have it, and we tell them, no, you have PTSD, you have depression, you have anxiety, and you're also extremely smart, which also plays into it. And then they get very upset because they feel
They've
like,
been misdiagnosed.
this
Yeah.
is the diagnosis I was given, I want
Sure.
this medication.
Sure.
The only way I can get this medication is to show that I have a diagnosis, and they can get very upset. And again, it comes back down to misdiagnosis and misunderstanding. There's been a great deal of research and advancement in both diagnoses, and I just wish people would better inform themselves, read text, read books.
Yes.
Not just
and there's
Google
spare
it.
time in understanding the information. I don't mean to interrupt you, because I think it's a very important point. Because as we were talking earlier, we want people to be self-empowered. We want them to be able to know if there's an issue. And for the medical field in my area, I go to entrepubmed.gov, which is a list of all the peer-reviewed publications that is open to anybody. Anybody who wants that information can get it.
Yep.
It's ENTREZ pubmed.gov, and we'll put that in the closing credits. But do they have something like that for mental health, or is that included in what we have?
It's included in what you have, but it's more research studies that come out. And I've actually, when I was in school, I had the greatest opportunity to access all these different research material, right? But once I got out, that was quite expensive as, a person, but also as a business.
Sure.
It's quite expensive to pay for those.
Right.
So what I found is when I started Googling something and I look at just the synopsis,
Of course.
then I make the determination,
If you should
do
go
I
further.
want to go further with this?
Yeah.
And that's usually what I do. And I probably have like 5 million small little subscriptions out there.
Well, and there's the issue. Again, it's wheat plus chaff, and which is germane to what you are looking for. And then add to that the intricacies and mosaicism that is in a person.
Yeah.
And I can see where your time, because you talked to me earlier about how much time is involved with the diagnosis and how you have to sift through the literature to be able to target your approach to this specific individual, which is a huge deal. It's not a cookie cutter thing.
No.
So how can you give it
So
the audience?
the process is quite intense. It takes about 12 to 16 hours for a neurocognitive to assess if someone has dementia or neurocognitive disorder due to TBI, alcohol, drug use, or a dementia process.
Sure.
And that can take a lot. And then you have the ADHD ones take about 10 to 12 hours, and then your autism about 10 to 12 hours. Psychological evaluation more 5 hours. But what it entails is as many interviews as we can possibly have with any providers they're seeing, records that we can obtain, medical, mental health, talk with a family member, someone who knew them developmentally, if it's, say, autism or ADHD, or a loved one who's been with them mostly throughout their adulthood. If we're looking at neurocognitive disorder, it's always great to get a loved one to do most of that interview so that we can understand what's going on.
Sure.
But we flip through hundreds of pages of record reviews, and then we have to summarize all of that. And our biggest
And then you
job,
have to then you have to intervene. Then you have to have an intervention that fits that particular set of diagnoses and findings. Amazing.
And then amongst that, you have all these different tests. So we're looking at language, adaptive functioning, which is activities of daily living. We're looking at memory. We're looking at problem solving. We're looking at attention. We're looking at a lot of different areas that can present differently and for different reasons. And then we're doing emotional and psychological testing as well to make sure that we're getting that whole picture. And our company logo has a puzzle piece, and it says, "Let's chat," or "Let's talk." And it's that for that reason. In therapy, we're looking to find out information, but especially in testing. It's our job to take all the pieces to the puzzle from birth to now, to sift through it, put it all together, and get this really nice, comprehensive clinical picture of what's going on internally, externally, physically. We often have to recommend medical tests as well. Got to rule out those causes,
Sure,
right?
sure.
To come up with a true understanding of what's going on. And now we got to look at the boxes of diagnoses, right? So we need to look within the box and see if they match these different diagnoses, if this diagnoses reflect what this person's going through, right? So we might look through and say, okay, let's look at anxiety, let's look at depression, let's look at autism, let's look at schizophrenia, let's look at personality disorder. We're looking at hundreds of these and doing a differential. In my head, it's very much like I've got a puzzle and I've just got a bunch of things out there, right? And then I'm grabbing it and I'm looking at it and I'm going, okay.
Does that fit?
Does this fit? Nope. Okay, we're going to put it to the side. This half fits, so we're going to put this to the side.
We're going to prioritize these half fits to the full fit. Yeah.
And I'm getting that picture, right? Exactly. And then I'm starting to put them together. But
like
then,
pixels.
Exactly. And then I have a timeline. So then I also draw out a timeline. I used to have to do it physically, but now I can do it visually.
Wow.
So I've done this so long now. But you look at it too, you look at the timeline and you're looking to see, okay, when did these symptoms start to pop up, right? Was it early development? Was it teenage years? Was it, after significant trauma? We really want to look to see that timeline because that makes a big difference too, right? It's called etiology or cause. If you don't really truly understand the cause, you're not going to get to that diagnosis, which then is super important in terms of recommendations.
Sure.
And no, we have some templates, with the basic recs for certain diagnoses, but we have to change that to match the patient.
Yep.
What's the patient's
tailor it.
cognitive strengths and weaknesses, mental strengths, weaknesses?
Yeah.
You have to tailor that. That's what takes the longest. For me, it's the impressions, it's the diagnoses, and the recs. That's what takes the longest for me
It's like a
as
mystery
a provider.
to solve.
It is. It's so neat. So neat. I become so geeky when I talk about this stuff.
Well, I can see why. I mean, it's like it's a world of possibilities, and it's your job to find. And in a way, that's medicine too, but it's not at all as extensive as you are describing. And perhaps it can't be.
I think
don't
it
know.
is, but just on a different
level. Well, it's interesting. It's interesting. I think there should be a good marriage of art and science and that empathy kind of feeling that you have when you're with someone as to whether they're trustworthy and whether you can really hear what they're saying that's obvious. And what are you're looking for the underlying causes more in some ways, and where the physician, so to speak, or the caregiver that we call them now in the healthcare field, is looking more as to how they can actually address these particular issues, enuresis, anxiety, which is not to be confused with something that's tangible. You know what I mean? But you're in that sort of murky world of finding these threads and tying them together into cohesive diagnosis.
And enuresis is a great example. I can't tell you how many individuals who have autism or are neurodivergent who have come to our door with enuresis as a
side effect,
as a diagnosis, a medical diagnosis, and it's really due to the sensory processing disorder or processing disabilities, because they don't have a technical disorder. They do medically, but they don't with mental health. That comes along with autism. It's the proprioceptive, the interoceptive systems. There's not working all that great. So with your interoceptive system, it's your messaging system. It tells your body when you're hungry, when you're full, when you have to go to the bathroom, when you don't. Even my adult individuals who are on the autism spectrum will say, I typically don't go to the bathroom until like last minute I'm about to have an accident. That's the interoceptive system not working properly. So it's not sending that message, hey, I got to go to the bathroom. So can you imagine young kids who are already trying to toilet? And those who are on the spectrum typically do toilet at a later age, still within the developmental age, but more towards like the end there, like 4 or 5 years old. And then maybe they're still struggling at 6 or 7 years old. But that may not be a medical reason. It may be medical mental health.
Well, we should have a two-pronged approach, I would think, from what you're saying, really. I mean, obviously we have to rule out the concrete things like, is there a urinary tract infection? And of course, if there is, that's a whole series of questions if that's the case in a child. But nonetheless, if there is some sort of a symptom that would have that individual, like a child and the parent of that child, come to either one of our fields and say, this child has a problem, then it's not just treating it for, if there's no infection, then what? Then do I have to think about a urogenital issue, or do I have to think about developmental? Do I have to think about if there's some sort of, is there a therapy? Is there an action? Is there something? Is there a medication that I give? There's a whole series of questions, but the complexity of your questions, I think, should be part of that thought process.
It definitely should. We're actually working right now on a model with another family practitioner.
Great.
We've been referring to each other for years. In fact, we've been door to door. Just happened to be that way, and we want to work on a model in New Mexico to have both medical and mental health in the same agency.
Sure.
Not like, big hospital kind of setting, a more intimate
a one-to-one thing, yeah.
So that we can, as a group, as a team, look at it, yes, from a multidisciplinary approach, but bringing medical into it, bringing mental health into it.
Sure.
And advising from both fronts.
Well, yeah.
We're very excited about that.
That is exciting. That really is, and I think it's long overdue. I really think we've needed to be cooperative for a very long time. That's the whole issue of healthcare, I think, and I think we are falling apart in the state. From what I hear from a lot of people is that a lot of people are actually moving out of state because they feel they can't get health care here. They just feel they can't. I don't know if you encounter that at all.
I have, but the problem is more global.
Yes, I agree with you.
It's not just New Mexico. Like I said, we have a location in New Hampshire as well. It's not, it's not
confined to our state. I do understand that. Well, the whole medical system, I think, needs to kind of beef up and be able to work with each other to be able to, we're not an ivory tower. We just are not. And I think the kinds of situations that you had run into where someone is misdiagnosed and perhaps diagnosed as ADHD or schizophrenia in their teens, where they could have really gotten so much more education that was more tailored to them if it were diagnosed back in, who knows? I mean, we'll have to think about early triggers for what you want to look for.
We had a 23-year-old came in diagnosed with schizophrenia. None of the history supported it. Schizophrenia.
Oh, schizophrenia. Okay.
Yeah. None of the history supported it. None of the presentation. Medications have never been effective. When we looked at it, he actually was very much intellectual developmental disability from a young age with a significant language disorder. And then he had some post-traumatic stress disorder, and so he was dissociating. So it wasn't what they thought it was all along. Now he's 23 years old and he's struggling to get services because his mother's sick.
These are tragic cases, and we know them all. I mean, we have all been exposed to that. If we've been in the healthcare field, we want to, minimize the tragedy. Just let's minimize the tragedy.
Sure.
Well, I mean, there are certain therapies that they do for cognitive disorder, for traumatic brain injury, PTSD, like in the football field for kids that are undergoing head trauma. And I know that one of the therapies I know is hyperbaric oxygen, but I don't know what other therapies they use.
They have cognitive restructuring. It's more a medical side of things, less psych. But they also have not biomarkers. I can't think of the therapy right now, but maybe it'll come to me later on. But it's a great treatment that is fairly new, last 10 or 15 years.
Not cognitive behavioral disorder. Okay.
No. I mean, CBT is something that I think is just kind of weaved into almost everything. But this is more of a neurobio approach.
Well, it's interesting that you said that, because I mean, just speaking for my own personal life, I had a dog, a German Shepherd, who was very, very anxious. He was a pound pup. And I didn't know quite what to do because he would go into these anxiety episodes. He didn't know exactly how to stop. I mean, even he tried to, but he just couldn't seem to do it. So in desperation, what I would do is take him by his collar and walk him in a circle, just continually walk him in a circle until he stopped, and then reward him. It seemed to make a slight bit of a change. So repetitive activity seemed to derail that circuit that he was in. But I don't know if you've ever heard or thought of anything like that. Is there something like that in the anxiety field?
Well, I mean, the thing that comes up to me or comes to mind is operant conditioning.
Operant conditioning?
Operant conditioning is wonderful to utilize with anxiety disorders. You'll also have exposure response prevention, which is wonderful.
Could you explain that?
Yeah, so exposure response prevention, let's think of somebody who has OCD, and it's combined with CBT, so cognitive behavioral therapy. So you're looking at the cognitive distortions that just come, and it's really more of a chemical imbalance, right? It has to do with your serotonin levels.
Associated with
to simplify it. Yeah, to simplify it, it's very much associated with an imbalance with your serotonin levels.
Okay.
Very, very simplified. But it causes these thoughts of really bad things happening, lots of fearful things, like say, and I am OCD. I was diagnosed with it when I was a young child therapeutically, but also through evaluation as an adult. And it makes you think that really bad things are going to happen. So for example, we've got all these coyotes around, right? I have these wonderful, beautiful, loving beagles, and they love to be outside. And the first thing I did was, we had already a 6-foot tall wall surrounding our yard. The first thing that I'm thinking about visually, and also just thinking about it, is this horrific thing happening to my dogs. And I was so anxious about it, and that's all I could keep thinking about, that this was going to happen. It was intimate, it was going to happen. And the only way that it was going to fix it is if I, engaged in, I don't remember what it was, but engaged in a certain practice, like a certain behavior. Some people count, some people line things up.
That you assign yourself a behavior.
Yeah, so if I do this bad thing isn't going to happen.
Oh, I see. Okay.
So it's a logical, it doesn't connect. Right?
Right.
So it's a logical thought that I should be worried about it, but the fact that I'm going to perform these behaviors are going to stop that from happening.
Right. There's no connection.
That's illogical. That doesn't make sense.
But
my
the
brain goes
emotional
there.
relief that it gives you. Oh, this is what I'll do. I will count, for example,
and then
that relieves your anxiety.
And that relieves my anxiety for the most part.
For the moment.
Practically, we just raise the fence, but it's even stupider things than that. Like when I was in school, if I was going to fail a test that I knew I was ready for, but I was going to fail that test if I didn't, make sure that I washed 3 times a day or whatever. So this thinking doesn't connect.
Yeah.
So you use CBT with that in part to identify what are the distortions, what isn't really going to happen, right? Like, let's think about what's causing this stress. And then what behaviors are you engaging in that, right? And so you're looking at the cause for it, and sometimes it's an antecedent, sometimes it's something that just happens in the environment. Maybe you watched a plane go down on a movie, and so now you're terrified and think that's going to happen. So every time you go on a plane, you say this mantra or whatever because you think that's going to stop you. So with exposure response prevention, with CBT, you're identifying the antecedent, you're identifying the behavior, you're identifying the thought, and you're looking at the connections between them. And then you're working on thinking about it differently. Right? Kind of fighting it. It's almost like you have an OCD demon here and an OCD angel here, right? And you're trying to kind of combat that, right? And there's a lot of different strategies to use within a CBT model. But then you have the exposure response prevention model, which is you expose yourself to a situation that causes significant anxiety, but you don't engage in that behavior. So you're not allowed to engage in what's called an avoidance behavior.
So let's take the airplane.
So if I go on an airplane, I don't say the mantra. I'm going to actually go through the flight, and I'm going to do the flight, and I'm not going to say that mantra. I'm not going to do anything to try to prevent this bad thing from happening, right? Getting and crashing. And I get off the plane and I'm fine, right? And I do that multiple times. And I do that until I'm not anxious anymore, and those thoughts just don't come up anymore.
It sounds as though this, although it's probably a tougher thing for that individual to go through, might be a better long-range treatment for that. I mean, I'm reading into that probably.
It's usually about a 6 to 8 session model.
Okay.
And again, you have a lot of different components there. So you
Sure.
have your cognitive behavioral therapy, you have your operant conditioning,
Sure.
and that kind of makes up your exposure response prevention. So it's again, I've oversimplified things, but it's really unique and it's very neat, and I've used it many times, and it's very effective.
It works.
Yeah.
Well, whatever works that doesn't harm that individual or harm others, it sounds like a good idea to me. So, I mean, from the standpoint of mental health, and I certainly am not speaking from a psychiatrist standpoint, I'm no expert in this, but in the course of like usual medical practice, you do encounter a lot of depression, which in many cases, in the case of chronic disease, is associated with depression. I mean, it's hard to not be depressed if you're chronically ill. And a lot of that is very specifically related, but that overriding kind of depression stops so many things from happening that are good for you. How do people deal with that? How would you suggest people deal with that if they have that?
Yeah, I think getting help is the biggest thing, but many people just don't want to admit it. Admitting it to yourself and admitting it to others makes you more depressed, right? So it's a vicious circle. I always say, if you can at least start doing something different, one thing different daily that you haven't been doing. If you've been sleeping a lot, then set an alarm.
And force yourself to get up at that time or whatever.
Force yourself to get up within 8 hours versus 10 hours. That's something different. Or if you're just kind of laying on the couch and watching TV and that's all you're doing, even if you're in a ton of pain, you can go ahead and get up and walk to the other side of the room. These are small steps. And of course you want to change that to bigger and bigger and bigger and bigger. But once you just start making that one simple change in your routine, you actually start to feel a little bit better.
Yeah.
And then the more you do it, the more you're willing to, okay, now let me admit I'm depressed and I need some help. So let me reach out.
Sure.
And then you'll work with a therapist. There's a lot of different approaches, as you can imagine.
It's starting it that I think is the big stopping gap, so to speak. I'm not describing it properly, but initiating and, as you say, pointing out to yourself that, I could really help myself with therapy. This can help. I've also heard a lot of people talk about, it's not really me, it's my spouse, it's my partner, it's my girlfriend, it's my
because
boyfriend.
they can't take responsibility and they don't want to admit it.
Sure.
I mean, if you admit that the problem is you, that can feel very hopeless. You can feel very helpless.
And yet it's the most critical, empowering thing I think you can do, because
Absolutely.
once it's within your purview, I guess I can do something about this, or you can find ways to deal with it. I believe that, again, maybe an oversimplification, but at least you know that where to look, And if that's something that we can, in fact, two of the things that I'm thinking of that you may want to pass on to our audience as to how they can take care of themselves from your expertise.
Absolutely.
Tell us, Stacey.
Sure. Well, first of all, sleep, super important. Many people don't believe that, and they're like, oh yeah, it's okay. But if you really think about it and you really monitor yourself, try identifying that. So say you get 5 hours of sleep, but you're usually a person who needs to get 8 or 10 hours of sleep and you didn't get that. Monitor yourself the following day. Are you more able to handle things that disappoint you? Things that don't go the way that you expect? Are you more irritable? Less accepting of others and less accepting of people seeing things in a different way? Are you able to think as long or stay on a task as long as you usually do? Guarantee you, those are all going to be no's. It's really hard when you have less sleep to be able to mentally and physically do what you're expected to do every day. Quite frankly, we have a lot to do every day. Even if it is getting up, taking a shower, and doing your hygiene. that can take a lot out of a lot of people, especially when depressed, especially. So if you are depressed, if you feel like you're sad a lot, you're finding that it's harder for you to get through your hygiene and you're starting to skip those steps. Don't. Go through the hygiene, go through the routine. Keep yourself trying to keep moving forward. It's when you stop, that's the hardest to move forward.
Inertia. Overcoming that inertia.
Absolutely. And it's called
That's
anhedonia
advice.
too. It's just, when you're depressed, again, that's another chemical issue, right? You have to then be stronger mentally by pushing yourself through things that your body and your mind's telling you not to do. So that's really important. Sleep, super important. Sleep actually factors into many of our diagnoses that we diagnose.
It's ubiquitous.
Factors into many of our problems, medically and physically. So that's super important. Eating healthy, another very important thing. I noticed once I stopped eating, takeout or, not the greatest kind of food, I was feeling so much clearer cognitively. I had more energy. It's amazing. And actually, I got to the point where I fasted maybe a little bit too long. I have to remember to do water when I fast, but I was doing intermittent fasting at one point and it was wonderful, but then I just kept fasting and it wasn't so great. Your body needs water, it needs nutrients, it needs proteins. You have to make sure that you're eating right. There's plenty of nutritionists out there. There's plenty of nutritional coaches out there, people who have a certification, who are a little bit cheaper and easier to get in with versus a nutritionist that works, in a bigger hospital setting. But nutrition is super important. And then physical health and working out. If you're in a ton of pain, working out is almost near impossible. But that also feeds into depression and anxiety and all these other medical things. So there are things you can do even from a chair. You can do chair exercises, which does not require you to stand up. You can, if you can walk, or even if you walk with a walker, walk across the kitchen, with a walker.
Sure.
Small steps. You don't have to do these huge, large workouts like you see on TV or read in the magazines.
That's right. Yeah.
So just little things, but those are the key things. Really, honestly, and it'll keep you physically and mentally feeling a lot better.
Yeah. And
recognizing things in yourself and giving yourself the okay and the grace to not be performing at 100%. And
you're allowed to be human.
Yes.
You're allowed to be human.
Absolutely. I tell people that all the time. They're like, I'm so sorry I'm crying. Why? You're human. You have the waterworks. It comes out.
Yes.
Keeping it all in, that's poison.
Yeah, that's right. That's right. I can't tell you how much I've enjoyed this. I don't know exactly how much time we have left, but I'd like to thank Stacey, Dr. Stacey Goldstein-Dwyer, who will give you information in the credits as to if you need to get hold of her or her company, her service. But we thank you so much for your volunteering to come here and avail us of your expertise. Thank you.
I can go further, so maybe
another one. I know. Can't we both? It's like we could just chatter forever. But I think that's it. And so thank you so much, Stacey, and thank you for listening in on us, and we're so happy to have you. So if there's anything that you would like to comment on, you're welcome to do so. That information will also be in the credits, but we'll see you later from Here for Health, and thank you so much. Bye-bye.